Webinar series. I am Nicolas Kozakowski from the Medical University of Vienna in Austria. And on behalf of the RPS Education and Training Committee, I will moderate today's session. I'm pleased to introduce today's speaker, Jeroen van der Laak.
Thanks a lot, Nicholas. And sorry for, I think you got the long version of my CV today. Sorry for that. Thanks a lot. Thanks for inviting me to this session. I'm very happy to be here. Actually, I'm quite surprised to see so many people show up on a Sunday afternoon even. So I will share my screen. Let's see how this works. Yeah, you should be able to see it now.
We see the first screen or the second screen, but we do not see the presentation. Yes, now. Perfect.
It should be better, right?
Yeah. Okay,
I will not be able to see all of you, so if there is anything you want to drop me, then please let me know. But I think we are good. Today I would like to show you some of the work we have done in the kidney field, kidney transplant field. So this is a research line that I've been doing for the last, I think, probably 7-8 years. And I will just give you a bit of an overview of what we have done, where we are now, and also a bit what we are planning to do in the near future. So nothing complete, but just, let's say, ongoing research. And of course, I have to show you my financial disclosures. And as Nicholas already said, I am the CSO for EUSIN. And apart from that, I have some companies that I worked with in the past. None of this will influence my presentation today. Well, I think for the audience today, this is not a big surprise. How we realized that kidney transplant biopsies are, let's say, the gold standard for diagnostics. If we really want to know for sure whether there's a rejection or not, the biopsy is still the way to go. Gives us the histopathological assessment gives us essential prognostic information. And this is really important because we still realize that long-term survival of renal transplants is still not optimal. We have 50 to 70% grafts that are still functioning after 10 years. So we need biopsies and we need assessment by pathologists to guide the treatment decisions. And I think you all are also very much aware of the Banff classification system. So the Banff system for kidney transplants, we have 6 categories. And the categories, the diagnostic categories, can be reached by scoring a whole range of different Banff lesion scores. And please don't even try to read this table. But you will be aware that we have a lot of these Banff lesion scores. The system is constantly evolving. And these are the categories that a pathologist needs to score to, in the end, come to a final diagnosis. And just to give you an example, what you can see here is on the left, we see a normal kidney. And on the right, we see a diseased kidney. And if you're a pathologist, you will see that there is a severe glomerulopathy. We have moderate peritubular capillaritis, and we have mild tubulitis. So this would probably result in antibody mediated rejection as a diagnosis. Now, we know it's not always that easy. And for instance, in this case, is there glomerulopathy in this kidney? And you may want to argue it could be that we see a few inflammatory cells. But it could also be endothelial cells. So we are not completely sure there. Maybe even more difficult, we see there is a lot of inflammation here. But then, of course, the question is, where is it located? Is it in the peritubular capillaries? Is it interstitial? Is it somewhere else? And how severe is it? Is it mild, moderate, severe? So it's not easy. Now, in this case, for instance, what we did was we restayed the same tissue section with a CD34 because we know it's important for the final diagnosis to see where the inflammation is present. And if we overlay, so we stained for CD34, and then we took the profiles of peritubular capillaries, and if we overlay these onto this PAS stained image,